The following presentation is for educational purposes only and should not be construed as individual or personal medical advice. It is strongly advised that you consult with your personal physician before making any changes to your medical health program or medications. Never stop or change any medication or medical treatment without first consulting a licensed professional medical provider for your individual medical conditions and needs. Welcome to my cholesterol mini course that I'm giving for you. The most common question that I get from my patients over the last 20 years is, what about my cholesterol if I'm doing this ketogenic or carnivorous diet? What should I do and what do I do about it? And so I thought I would do a mini course on this and provide this for those that wanted to learn a little bit more in depth about cholesterol and have something to reference to in regards to what their cholesterol function can do. So I'm recording this evening. It's the evening time. I'm home and thought I would just go through this with you guys and provide this for those of you who would like to learn a little bit more about cholesterol. So let's just dive right in and we'll go to it. So the first thing that's important to understand is that men are often too weak to follow their own best judgment. And you're going to see this as we go through the information and a lot of the science that we've known for the last 15 or 20 years, and yet how we've persisted in the use of cholesterol treatment and the prescriptions that we use for it. So let's dive right in here. So one of the things that I often say is that knowledge is the piling up of facts, and wisdom lies within their simplification. This is a stool sample that was actually given to me by a patient as a joke one day. But in essence, it's the important thing about understanding the vast of knowledge that we have is trying to create some wisdom out of it. So let's go into it. So I usually want to talk about sugar and how it affects our body, how it raises insulin. These are the basic components of glucose or table sugar, which is sucrose. It's a glucose molecule and a fructose molecule stuck together. And just to get you some basic understanding, a lot of people don't understand the difference. Well, the fact that we often refer to carbohydrates. A carbohydrate is one of these glucoses or a fructose or various forms of the basic sugars that are bound together with glycosidic bonds, creating longer chains. In your stomach, your body breaks it down into the basic components of sugar. I wanted to also give you some carbohydrate equivalents of food. So remember that your piece of bread is essentially 5 tablespoons of sugar. Your apple is 4 tablespoons of sugar. Your banana is 8 tablespoons of sugar, and your bagel is about 12 tablespoons. Teaspoons of sugar. I said tablespoons. These are teaspoons. These are literally referencing to 1 teaspoon of sugar is essentially 4 grams of carbohydrate. So your piece of bread is about 20 grams. Your apple is about 15 grams. Banana is 30. Hopefully that gives you some reference range on that. So a lot of people say, well, Dr. Nally, I didn't eat any sugar, but yet they ate a banana or they ate an apple or they had some pasta. Again, it all turns into glucose or fructose in the bloodstream, and it's still used the same way, producing an insulin response. So the normal plasma blood sugar should be somewhere between 70 and 95 milligrams per deciliter. If you're across the pond on the other side of the country or the world, it's about 3.9 to 5.3 millimoles per liter. Now, when you eat some sugar or carbohydrate of any sort, it produces insulin. And that insulin stimulates a whole slew of responses in the human body. Too much insulin drives inflammation, it drives weight gain, it lowers nitric oxide, which affects blood pressure by raising blood pressure and raising sodium retention, which is what causes people's legs to swell and causes them to retain fluid in their legs. It increases uric acid and calcium oxalate, which lead to kidney stones. And what we're going to talk about today is how the higher insulin drives up triglyceride and the cholesterol molecules. We'll dive into that. It also increases free radicals. It increases thyroid peroxidase antibodies, which is the driver behind Hashimoto's thyroiditis. We'll talk about that another time. And when you have high levels of insulin, it actually raises estrogen in men and lowers estrogen in women. It raises testosterone in women and lowers estrogen in men. So it basically turns men into women and women into men. That's the driver of high insulin production. So it's important to understand that we want to keep our insulin at the baseline and not let it stay high all the time, which is what happens with insulin resistance. And hopefully you understand that concept of insulin resistance. If not, you want to reference that on my blog or in some of the other articles that we've talked about. Now, as you eat a fat or something that contains fat, the fat is broken down in these little molecules. These little blue heads with yellow tails are what's referred to as triglycerides. It's a molecule that has three little glycerin tails, and that's absorbed through the gut wall, which is what they're referencing here. As it passes through the gut wall, the blue head sits on the outside, and the tail is on the inside, essentially. So the triglycerides inside this little bus or chylomicron that carries your fat up and down your bloodstream. Now, the chylomicron is the largest cholesterol molecule, and as it passes up and down the bloodstream, if insulin is present, insulin signals this little molecule called lipoprotein lipase to bond to this molecule. It's like the Star Trek Enterprise docking, and all of the triglyceride is pulled from the chylomicron into the fat cell or into the cell. This is essentially how fat gets into the fat cell. You cannot gain weight if you don't have insulin to trigger the lipoprotein lipase and turn it on. That's why if you see a type 1 diabetic who's not taking his or her insulin, they are going to be skinny as a rail. Now, I don't recommend that because there's a whole slew of disease processes, including death, that arises if you don't have an adequate insulin. But you'll notice that all of our type 2 diabetics or our patients who are insulin resistant, they're basically pre-diabetic, are overweight. And that's because the higher level of insulin production is actually stimulating them to store fat at a much more rapid or higher rate. Again, that's another topic, but it's important that you understand the basics that high levels of insulin in response to starch or sugar is the driver of fat entering the fat cell. We're also going to look at how this affects cholesterol now. So this is an artist rendition of a cholesterol molecule. And on the outside here, you have phospholipids, which make up the outer walls of the molecule. And then there are cholesterol molecules both on the outside and on the inside. Now, if insulin is high, the cholesterol is not esterified, meaning it doesn't have an ester bound to it and it can't get pulled inside. But if the cholesterol is esterified, it can slide easily through and gets transported inside the molecule. There's an inverse relationship with insulin and cholesterol ester. So as insulin goes up, the cholesterol cannot be esterified and it stays on the outside. And as it is more normal or at a baseline, then the cholesterol is esterified and it's pulled inside with the triglyceride, if that makes sense. Now, these are we reference the chylomicron, the largest cholesterol molecule, and that's what this is right here. There are VLDLs, there are LDLs, and then there are HDLs. There's the ILDL as well. Multiple types of cholesterol molecules, and I want you to think about the cholesterol molecule as a bus. And then again, your cholesterol esters are either on the outside or inside, and the triglyceride is on the inside of these. They're basically buses for triglyceride and cholesterol. That's what they are. Now, we know that the LDL is the bad one, HDL is the good one, which we've referenced to for 50 years, but we're going to learn a lot about LDL today and how not all of them are bad. And so that's what I wanted you to look at. The HDL is the smallest molecule. The LDL is a little bit larger, and the VLDL are the big ones. LDL is essentially a cholesterol that's being pulled back from the tissues. HDL is going to the tissues essentially, and so and as are chylomicrons, and we'll talk about that here with this slide. So you can pull fat from the intestine into the chylomicron, and then that chylomicron transports that cholesterol remnant down through the body. And as it's going along, the lipoprotein lipase is signaled and fat is pulled into the peripheral tissues to be used as fuel. And that's essentially what this slide here represents. The liver also makes VLDLs, and those VLDLs act similarly to chylomicrons, and they'll transport fat from the liver to the peripheral tissues. And as they get smaller and smaller, as the fat's pulled out through the lipoprotein lipase, then they become LDLs and they're transferred back, if that makes sense. So hopefully that's kind of somewhat clear to you in that regard. What I wanted to point out here, some of these important things, is that cholesterol is essential in making hormones, specifically progesterone, DHEA, testosterone, and cortisol. If you're under lots of stress and you don't eat enough cholesterol, you actually won't handle that stress very well. And it's important to understand that if you don't take in enough cholesterol, you actually will see low testosterone, low estrogen, low progesterone. And this is a huge driver for hair loss in women. It's a driver for low testosterone in men, especially those that are doing vegetarian or vegan diets. And this is important to understand that, and very few people reference this when they talk about low-fat diets, but this is a huge culprit that I see in my office and a driver of a lot of pathology. I want you to understand that cholesterol is essential in the production of vitamin D. If you don't take in enough cholesterol in your diet, your body cannot make adequate vitamin D, which is important in metabolism. And so you get some of the cholesterol from your dietary intake, and you make some of it from the cholesterol in your body, and this creates these two, the pre-vitamin D and the dietary intake components of it allow you to make vitamin D essentially. So it's important to understand how cholesterol plays a role in that formation of vitamin D. Lastly, cholesterol is essential in the formation of bile acids. A lot of people who are doing low-fat diets or vegan diets and are not eating fat and cholesterol end up having GI upset, inflammatory bowel, and irritable bowel because they just don't make enough bile. Bile is essential, and you'll notice that cholesterol plays a huge role in the conjugation and formation of bile and allowing your body to absorb fat within the gut. So I just thought I'd point that out there. Now, well, the biggest question I get is, well, Dr. Nally, if I eat a diet that's high in fat, won't that raise my cholesterol and raise my risk for heart disease? And this is literally the question I get asked 10 times a day, and I've been asked this question for almost 20 years. And so let's answer that question. As we answer it, it's important to understand the current trends of thought that have been around for the last 50 years. Number one, we've been told that we need to aggressively lower LDL-C. That's been the cornerstone of preventive cardiology. And even today, I had 2 patients that told me their cardiologist was just insistent that they lower their LDL-C. We're going to talk about why that is not helpful and why that's actually a problem. Statins are the go-to prevention for this. They basically want to slash the LDL-C levels and the total cholesterol levels because they use it as, quote, a surrogate marker for cardiovascular disease. And we're going to learn that that's actually not scientifically valid. Everyone over the age of 50 should be on a statin to reduce their heart disease risk. That was actually quoted in a couple of journal articles and in the Journal of Clinical Pharmacology. So it's important to realize that this is actually what's being said and has been said over the last 5 to 10 years. I've had some patients actually say that, or I rephrase that. I've had some physicians and or pharmacists say that we should be giving children statin drugs to lower their LDL-C as young as 8 years old. Again, we're going to look at how problematic that can and will be. Recently, I was in a conversation with a pharmacist, and she said, quote, "We should be putting the statins in the water." And I almost had a conniption fit, and you're going to see why. But how did we get here? This is me, and this is my goat, so something to look at here. But as we dive in, I want you to understand some concepts that very few people understand. We're going to talk about absolute risk and relative risk. Now, relative risk is we take, for instance, if we have those that we put on statins and we look to see, so we have 100 people that were on statins, how many of them had a heart attack? That's what the top number is. And on those people that weren't on statins and those that had a heart attack, we take the two and we divide those together, and the number you get is a relative risk. If that number is greater than 1, then that means that the statin was helpful. If it's less than 1, it means it was unrelated, not helpful. This particular graph is just to show you that in these people who were exposed to traveler's diarrhea, this group got exposed, this group didn't. And so when you look at it, if you swam in the kiddie pool, these people who are exposed have 3 times greater risk for giardia. Now that's a relative risk. The absolute risk is the actual number. So if you have 100 people and 2 of them have a heart attack, then your absolute risk is 2%. The relative risk is always a bigger number because you're dividing those that had the issue and those that didn't have the issue, and it's a bigger number. So let me show you how that works and what that essentially means. So they had a study in 1984 where they took 3,800 men and they gave them cholestyramine or Questran. And they showed that there was an absolute risk reduction in heart disease of 1.6%. So if you were to take 100 of those men, 1.6 of them had a decrease in their heart attacks. Their total cholesterol and LDL-C decreased. The total cholesterol decreased by 8% using this particular drug, and the LDL decreased by 12%. But there was no actual risk reduction in death from heart disease. And that's really what we're looking to do is if you're going to have a heart attack, we want to stop your death from heart disease with medication. But when they gave these patients the cholestyramine, there was actually an increased risk in death by all other causes. So the question is, yeah, you're stopping a heart attack, but if you're actually causing more heart death by other causes, is that really a good thing? That's never talked about. But what's interesting is they said, well, look, the absolute risk reduction was 1.6, but it had a 19% relative risk reduction, and that's a big number. We like that number. And so what ends up happening, if you look at this from the perspective of what's important, if you were to treat 100 men, you'll only stop 2 heart attacks, but you won't actually reduce death from heart disease, but you might increase the risk of death from other causes. But to sell a drug, they said, well, 19 is better than 1.6. So they always talk about relative risk reduction because it's always a bigger number, and that sells you the drug lots better. So 19% is much bigger than 1.6%. And so you can always use a relative risk reduction to sell a drug better than you can an absolute risk reduction. So it's important to understand that. All right, here we go. So let me define what LDL is actually. So an LDL, there's LDL-C, which is basically a calculation. It's not actually measuring the actual overall LDL, but if we measure the actual number of LDL particles, we stick your blood under an MRI scanner, we count the number of particles. That's essentially what the LDL-P number is. It's a particle count. But when we measure LDL particles, there's actually three subtypes that we're measuring. That we're measuring the big fluffy particles, we're measuring the intermediate particles, and we're measuring the small dense particles. So with these molecules, it's important to understand that you've got the esterified cholesterol, which are the cholesterol molecules that are pulled inside the lipoprotein. There's unesterified cholesterol. These are the ones that are stuck to the outside because insulin was high when those were formed. There's apolipoprotein B, which we'll look at here in a minute. And then there's the phospholipid, which is the outside. These are the big fluffy ones. You have the medium-sized ones that have more ester on the outside, more unesterified cholesterol on the outside, less esterified cholesterol on the inside. And then you got the small particles, which have a ton of cholesterol molecules on the outside and much less on the inside. So what makes them small is that there's less cholesterol inside and more ester on the more unesterified cholesterol on the outside. So we want to esterify our cholesterol. That's the important thing. And that's what these two articles in Diabetes in 2003 and in the Medical Archives in 2018 reference to. I often will tell patients, well, it's kind of like these unstable buses you see down in South America where there's just way too many passengers and they don't have a good seat. These are the dangerous ones. These are the ones that cause problems. And so if all your passengers are inside the bus, you're great. But if the passengers are stuck outside the bus, you have major problems. And essentially that's what's causing the damage to the vessels, which we'll look at here in our arteries. So let's look for a moment at what the marketing does to tell you to buy a statin and why this is a problem. So atorvastatin, which is Lipitor, the absolute risk of a coronary event is 1%. So if I give 100 guys a Lipitor molecule or drug, I will stop one heart attack. But the relative risk calculation of that, so of 100 guys I give, it'll decrease the risk of one heart attack in that group of 100 men. But if we calculate the relative risk of that, it's 36%. Now, 36 is much better than 1%. So that if I tell you, hey, you have a relative risk reduction of a coronary event by 36%, most people interpret that to mean, oh my gosh, 36 out of 100 people didn't have a heart attack. That's actually not what it means. It means that your risk of those that had the heart attack versus those that had a heart attack that weren't on a statin is 36%. Again, the number is mismarketing. You can see here, 36% of patients, the relative risk reduction here in their advertisement. This is the advertisement from Lipitor itself in 2007. It's actually 1.6%. I put one there, but it's a 2% risk reduction here. You can see that that's the actual risk reduction versus what the relative is. Now, most people will understand if you say, we stopped 1.6 or 2% of patients from having a heart attack if it was 100 patients. But they actually use these numbers of the relative risk, and that's the problem. Quest Store, it's a 1.2%. Relative risk is 44%. Again, you can see 44% sells a whole lot more drugs than 1.2 does. That's important today. But if you look at the most recent studies, 2016, in the British Medical Journal, they showed that giving the folks in the Western European countries statins is for both primary and secondary prevention, meaning it's the primary preventer or secondary after a heart attack. There was no clear reduction in heart disease mortality. You didn't decrease death from heart disease by giving these drugs. A second journal article in 2017 showed that there was no benefit whatsoever of giving statin drugs to the elderly. Those are patients over 75. And actually an increase in all-cause mortality in giving 75-year-olds drugs. This is a major problem, but nobody's talking about this. Third article, 2015 British Medical Journal, there was the median life expectancy increase if I gave you statins was 4 days. I increased your life expectancy by 4 days. However, there was an increase in all-cause mortality, as you can see in two other studies. So that's the question is are we really benefiting people by giving them statin drugs, especially after age 75? Very important to understand. So now, what's also important to understand? Well, no one references these studies here, but in 2021, we actually showed that if we lower your LDL-C, it increases all forms of dementia. If we lower your total cholesterol, it increases all forms of dementia, and it increases Alzheimer's dementia pretty dramatically. There's an inverse relationship. As I lower your LDL and total cholesterol number, this is not the small particle, this is just the LDL-C, the calculated one or the total, then your dementia risk goes up dramatically. 2 different studies referencing this in the last 20 years. Now, if I lower your LDL-C, the question is, they did a literature review trying to determine, let's look at all the studies and see, was there a change in mortality or death if we lowered the LDL-C, or if it increased? Does heart disease increase when it happens? And so they looked at 19 different studies, and the result was that as your LDL-C went down, your risk of death went up. And that's 19 studies that they looked at showing that. That's pretty significant. So as your LDL-C drops, your risk of death goes up. Do you really want to be on a statin drug? Because that's what the 19 most prominent studies are showing, and that was the review of in the British Medical Journal in 2016. Nobody's talking about this. Now, the blockbuster drug, I had a patient come in today that actually was placed on Repatha, or one of the generics related to Patha, these PCSK9 drugs. They said, oh, these are fantastic. Well, there was only a 1.5% absolute reduction in non-fatal disease, but it didn't reduce mortality either. So this is identical to statins in their effect, but it's a shot you take once every 6 months rather than a pill every day. And they showed there was no benefit in preventative outcomes. And the take-home message from this study was that no one taking this drug, this shot, lived any longer than the placebo group. That's a problem. But yet it costs a fortune, and it'll lower your LDL-C by a whopping 60%. But as we just saw, if I lower your LDL-C, we increase your risk of dementia dramatically. So that's important to understand. An interesting study looked at the Mediterranean diet. They said, what happens if we just change your diet? What happens if we just take some of the carbs out of your diet? That's what essentially what a Mediterranean diet is. A little bit higher fat, a little bit lower carbohydrate. And they actually showed that there was if we talk about risk reduction, a 29% risk reduction of recurrent heart disease, 19% risk reduction in cardiac death, and a 40% risk reduction in all other causes of mortality if we just lowered your carbs and gave you a little more fat. Pretty profound if you look at this. It's actually quite impressive to see. So they did a meta-analysis of 21 studies, and they asked, what happens if we lower the LDL-C? Does it reduce death? By 0.8% in this combination of 21 studies. It decreases heart attack by 1.3%, pretty consistent with what you saw with the statin drugs. Does it decrease stroke by maybe 0.4%. Now, the odds of dying if you fall is 0.9%, and the odds of death by a gun assault is 0.5%. So by lowering your LDL-C, we're not doing any different. We're not changing your risk of death any more than falling or a gun assault. So that's something to consider if you look at those comparatively. The other concern that you see is since 2000, as we've lowered the cholesterol levels, the total cholesterol levels, as you see, we lower that, suddenly we start to see heart disease death start to rise. Pretty dramatic to see this change. This is a big deal. So again, as you're lowering the total cholesterol, we're seeing a dramatic, or actually LDL-C is what it is. We actually see a rise in heart disease, and that's from the December 2001 or 2021 Preventative Medicine article. Again, is lowering total cholesterol and LDL-C really what we want to be doing? That's important. The important question to ask ourselves in this regard. So why keep prescribing these statins? Well, the dirty answer is this: Medicare ACOs, these are the accountable care organizations, have basically incentivized cardiologists and family doctors and internists to lower your LDL-C, and they've done it by saying that, hey, if 80% of your patients are on statin therapies, we'll increase your reimbursement by 1% to 2%. Here in Arizona, where it's at, it's a 2% increase. Now, if you don't, and you don't justify why 80% are not on therapy, they actually cut your reimbursement by 1% to 2%. And so it really comes down to money. And a lot of people are horribly offended when they hear that, but that's really what the cause of the physicians continuing to prescribe these drugs is they've incentivized the physicians to prescribe them based on outcomes that are over 50 years old and actually don't have no validity any longer based on what we now know in science. All right, what happens if I lower your LDL or your total cholesterol? Well, if your total cholesterol drops below 170, then or your LDL-C drops below 130, you'll start to see fatigue, dementia, decreased libido. Again, we talked about how it affects cholesterol, hair loss, poor sleep, poor exercise recovery, suicidal ideation, meaning you start feeling depressed and suicidal. We see personality disorders, we see hypertension, and we see sodium go up and potassium goes up dramatically. Have you had a problem with sodium? Has your doctor told you, hey, you need to cut out your salt? This is why. If we lower cholesterol, we have all these issues arise. These changes occur literally within 4 weeks of lowering the cholesterol. I've seen it for 20 years, and this is one of the reasons that I do not prescribe statins, and I try to take people off statins if I possibly can. And I'll give you reasons to do that. Now, this is an interesting statistic. Is it correlated or not? You be the judge. I've had some people say, well, there's no actual study that shows this. I've just given you 4 studies that show that as you lower the LDL, Alzheimer's risk and dementia risk goes up. But in 1910, there were only 4 cases of Alzheimer's dementia. In 1979, there were 857. And in 2020, we've got 134,000 new cases of Alzheimer's dementia death that have arisen. This is a 15,600% increase in 41 years. Is lowering our cholesterol a problem? You tell me. I've got some puppies in the background, and you may hear them bark or mumble here. We got eight puppies that just got born, so I apologize if there's a little sound in the background. The puppies are having a ball. All right, so let's look. So an interesting study showed in 2013 that if in young adults, if we actually just decrease their insulin resistance by giving them less starch, we decreased heart attacks by 42%, and we decreased hospital readmissions with heart disease over 12 months. Dramatic change if we just improve insulin resistance. So you can see how profound changing your diet is in regards to preventing heart disease. Much more profound than giving you a statin drug or a pill to fix it. In another study, a lot of people say, well, how do you know, Dr. Nally? How do you know that insulin sensitivity is the problem? As we make you less insulin resistant and more insulin sensitive, your SDL, your small dense particle goes down, your LDL-C actually will go up. So a lot of people that are on ketogenic or low-carb diets go, oh my gosh, my LDL-C went up, and their cardiologist freaks out and wants to put them on a statin. Well, this is anticipated to happen. And in fact, it's more likely that this is going to happen if you're exercising 5 or 6 days a week, because your body's using more fat and it's going to raise the LDL-C. And I'll explain why here in a minute. But your small dense LDL will go down and your LDL-C will go up on a ketogenic or carnivorous diet. We've expected this. We've known this since 2003. Yet I'm not sure why so many ketogenic experts or gurus out there don't understand this concept. It's been in the literature for years, and so I'm not quite sure why so many ketogenic experts or gurus out there don't understand this concept, but it's been around for a long time. So what you can see here, just to recap, is that your small dense LDL particle number will actually go down as you increase your fat and protein and you decrease your carbohydrate intake and insulin. But your LDL-C may very well go up, and it goes up even higher in patients who are athletic or exercising 3 to 5 days per week or more. That's actually normal, and that's what this study shows from 2003. We've known about this for almost 20 years based on these studies, and so it's not surprising to see the LDL-C go up in that regard. So don't be surprised. If you're on a ketogenic or carnivorous diet, you're going to have a higher LDL-C. It's just going to happen. But don't let somebody convince you to go on a statin, and explain why. This is really the key to understanding cholesterol on a ketogenic diet. This is another slide to just show you the same information I showed you before, that as your as you lower the starch in your diet and your insulin level falls, you'll see a rise in the LDL-C number, but you won't actually see the small dense particle go up. That's what this slide shows. I won't dive into that one heavily, but I just want you to be aware of it. You can still have risk for heart disease even when you lower the LDL-C. That's the other component of this. If I drop your LDL-C down under 100, which is what this group is, they can still have high small dense particle and be at risk for heart disease. And I'll show you why that is in this way. So you can have an LDL-C, which is a calculated number, of 130 with a pattern A, which is lots of big fluffy cholesterols, or you can have a pattern B, which is a LDL-C of 130, but have lots of small dense atherogenic cholesterol molecules. And so that's the difference that we're seeing. Normally, a lipid panel done is a total cholesterol, HDL-C, and an LDL-C and a triglyceride. That's what most doctors order right now. The challenge is that this LDL-C can be misleading. You can have high-risk cholesterol or you can have low-risk cholesterol, but you won't know unless you actually check the particle number. And that's what this small dense LDL particle number here actually references. You can check it also with ApoB and LP(a). You can do it with an insulin resistance score. We'll talk about this here in just a second, but I want you to understand that this LDL-C number is very misleading because of this specific issue. So, all right, again, we talked about the size of the molecules and what they mean. This is another summary with 3 more slides or 3 more studies to just show you that the small dense LDL particle is more atherogenic. We've known that since 1999. The small dense LDL particle oxidation is driven as you esterify a cholesterol, it becomes less problematic. As it's non-esterified, it's more problematic. The small particle is the most potent inflammatory effect, has the most potent inflammatory effect on the vessel wall. We've known that since 2017, and it was implied in 2002 here as well. Important to understand. So let's look at the arterial wall. This is your artery if we cut it in half, and we're looking at the person that's 10 years old when they, or let me rephrase that. It's a person that has insulin resistance, and as we progressed 30 to 40, 50 years into this issue, if your cholesterols are predominantly small particles, meaning they're not esterified or the insulin's remaining high, for the first 20 years, you'll start to see this plaque build. Then by around 25 to 30 years, you'll start to see plaques that become pretty predominant. Once this area becomes narrow, one of the things you have to understand is that as blood flows over here, as blood flows through a more narrow component, the blood speeds up and the blood swirls and creates plaque, creates a clot, a blockage. And that can lead to stroke, that can lead to heart attack. And that's essentially what you're seeing with this happening. Now, as insulin stays high, you've got 5 different components that drive this fatty streak turning into a fibrous cap, turning into this unstable cap, and then a ruptured cap, which is essentially a ruptured vessel wall that causes a complete blockage. So you get C-reactive protein, which is increased inflammation that's occurring. It's driven directly by insulin. A lot of people say, well, I want my C-reactive protein checked. Well, if your insulin's high, I guarantee your C-reactive protein's high because insulin stimulates C-reactive protein. Your toll-like receptor gene starts to, with high insulin, starts to change the way the fibrous cap is made, and it changes the deposition of fat inside the vessel wall with macrophage changes and all sorts. There's a whole slew of physiology that you can study with that. I won't dive into that. Just realize that as insulin stays high over time, we see these hormones drive the processing of a ruptured plaque in the wall. And that's essentially what's occurring with atherosclerosis. In my office, we're doing carotid ultrasounds all the time, and I'm measuring what's the thickness of this wall here. Is there a plaque? We're looking for those things all the time. So important. Because the insulin's elevated, you see a decreased nitric oxide, you see vasoconstriction, you see depressed autonomic nervous system, and vagal tone decreases, which changes the way your body's using the production of CMP and fuel. There's an increase in lactate, and there's a decrease in calcium binding, which leads to arrhythmia. All of these are driven by insulin being elevated, so it's important to understand. Now, some people say, what about my ApoB? This was talked about a ton, and there's still cardiologists talk about it all the time. These 3 studies in 2009, 11, and 1999 demonstrate that when insulin is high and you have lots of small LDL particles, ApoB lipoprotein is preferentially bound to these particles. So as there's an inverse correlation. So as your particle size is smaller, you have more and more ApoB, which is the driver behind, which is one of the markers of risk for heart disease. And so it's important to understand that whether you're measuring ApoB or you're measuring the small particle, you're getting the same answer, essentially. That's what you're seeing. Now, as insulin goes up, insulin also increases the production of triglyceride at the liver level. So as triglyceride is rising, you're going to increase the production of those small particles as well. So insulin is raising triglycerides, and insulin is raising the number of small particles. That's essentially what this study is representing that was done in 2002, that as your insulin stays higher, you have more triglyceride, which increases your potential for fatty liver disease and increases your risk of increase your level of triglycerides as well, which increases pancreatitis risk. So as the small particle goes up, we see an increased thickness of the carotid wall or the arterial wall, which I showed you in the other slide here. This is just another study done in 2013 to demonstrate that this is actually true. So as your small particle is higher, you start to see thickening of the arterial walls, which leads to plaque, if that makes sense. So, study that was done by Dr. Shaya in 2010. They looked at over 2 years at a low-fat diet group, a Mediterranean diet group, and a ketogenic diet group. Hopefully you can see this. This is the low-fat group. This is the plaque. This is the carotid artery, which is measured in cross-section. This is where the plaque was measured out at right here. This is the plaque right here, and this is the plaque right here. So this is the low-fat group. This is the Mediterranean diet group, and this is the ketogenic diet group. Over 2 years, when they followed, there was some slight reduction in the plaque in the low-fat group, but no major change in the wall thickness. You had a subtle change in the Mediterranean group, but you had a significant improvement in the plaque and the intimal wall thickness with the ketogenic diet group after 2 years. I see this every day in my office. I see a 2 to 10% regression in plaque every year when a person follows a ketogenic or carnivorous diet, and it's actually pretty profound. So, to answer the question, well, Dr. Nally, what numbers should I then be watching if total cholesterol and LDL-C are not helpful? Then what should I be watching? Well, the two numbers that I watch very heavily is your small dense LDL particle and your triglyceride. Now, LDL particle, as we showed you, has three subtypes. There's the big fluffy ones, the medium-sized ones, and the small dense ones. That's the small here. So your LDL-P is going to be somewhere between 1,000 and 2,000. That's actually pretty normal. Most labs reference anything more than 1,000 being problematic, and that's actually an experimental reference range. They don't really know. We don't really know. Should this be 1,000? Should it be 2,000? Should it be 3,000? In most of my patients who are following ketogenic diets and seeing regression in plaque, their numbers are somewhere between 1,000 to 3,000. So I'm not worried about how high this number is because this is a combination of all the big, fluffy, medium size, and small dense. What I do want to see, and it's important I've found in my clinic, is that we want to see the small particle number less than 500. And this number literally changes every 72 hours. So if you ate, depending on what you ate in the last 3 days, this number will change. So if you ate a bunch of starch, you're going to see a high LDL-P for the next 3 days. But if you eat really well for 3 days, we're going to see the small LDL particle drop below 500. Now, triglyceride changes every 24 hours. And we want to see your triglyceride less than 100. Now, most physicians want it less than 150. I find that unless it drops below 100, you won't see the small particle drop below 500. So this correlates directly with how this is going to occur. So your triglyceride needs to be under 100 for 24 hours to get this to start coming down to less than 500. Hopefully that's clear to you. So these are the two numbers I'm looking at. So when a patient comes into my office and their triglyceride is less than 100, I know, hey, you did well in your diet in the last 24 hours. If the small particle is less than 500, I know, hey, you've done well in the last 72 hours. So can you game the system? Yes, you can. So if you eat really well, for 3 days, you can get those cholesterol numbers to change. That's something to understand. Now, is HDL still a reference? It is, and because we know HDL is a good cholesterol. I look specifically at the calculated number still, and as long as it's over 40, I know that, hey, you're getting adequate exercise and or adequate omega-3 fatty acids. Those two things change the HDL-C, exercise and omega-3 fatty acids. And that changes about every, 72 hours, not 74. And then total cholesterol, we want your total cholesterol to be greater than 200. Now, if your LDL-C is high and your triglycerides are high, and this is higher than 200, that's a risk factor. But if your LDL small particle is low, under 500, if your triglyceride is under 100, anything over 200 means you're going to live a longer life. That's essentially what it means. And then again, total cholesterol changes within a 72-hour window as well. So that's important to understand and important to reference. So hopefully that gives you some numbers to follow. Again, when I look at my expanded cholesterol profile, I'm really looking at these two numbers, and that's really all I'm worried about, if that makes sense. So let's look at some data. This is a 78-year-old female patient of mine for about 10 years. At the time she was seen in 2015, she had impaired fasting glucose or prediabetes. She had asthma. She had a number of other medical problems. She was on a number of different drugs. She had actually had stents placed, and she was on Plavix. And so what we were looking for here is, what's her A1C? Well, what you'll notice is that when she came to me, she's in that pre-diabetic range with an average blood sugar of 6.1 on her A1C. That number should be less than 5.6. As she watched her diet over the next 6 months or 8 months, she lowered that A1C to 5.8 and then down to 5.2 in about a year's period of time. Notice her total cholesterol went up. Again, that's not bad because her small dense particle dropped from 481 down to 217. But really important to see that it changes. Now, it will flux based on what she ate those 3 days beforehand. And if you look at her triglycerides, the day before she came into my office, she actually was eating a pretty good diet. But 3 days beforehand, she wasn't. You can see that with this reference range here. So she's maintained her triglycerides quite well. Fasting insulin over a period of a year dropped from 26 to 12. It takes about 2 years for it to drop to about 5 or less. And we expected to see that, pardon me. And her glucose was maintained fairly well. That's her fasting glucose. So as you can see that over time, if you're following a ketogenic diet, you'll improve your glucose control, and you'll improve your cholesterol control. And again, I'm looking for the small particle to improve under 500. Now, this is Sonora Quest she went to, and I usually like to see those numbers under 450. That's why this is highlighted in red. Their reference ranges are slightly different, but most of the time I'm shooting for 500 or less. And then her fasting insulin, we're shooting for that to be less than 5. Hopefully that answers that question there. This is the same patient. You'll notice that in that time frame, when we measured the carotid arteries, these references are referring to the numbers here. So she had a 21% plaque in the internal carotid on the right and a 44% plaque on the internal carotid on the left. These are the arteries that go to the brain, that increased risk for stroke. Over that year period of time, she decreased the plaque from 4% to 32%. Pretty profound. I normally see 2 to 10%. She had almost a 20% reduction there, and she had a notable improvement in her plaque here as well. We see that the intimal thickness improves, and so she actually dramatically improved that there as well. So very important to understand that not only are you changing your blood sugar numbers, but you're also reversing plaque as well, and that's what that patient saw. This is a 75-year-old patient who came to me in 2014. You can see that this particular patient had an A1C of 6.4. He decreased it to 5.4. His triglycerides, when you follow the diet, would drop from 190s down to 98, and his small particle decreased from 700 down to 150. Again, this is what we're looking for. We're wanting to see these patients improve their cholesterol control, and that's dramatic. Now, what you'll notice is that his total cholesterol stayed elevated above 200, and his LDL-C stayed above 100. That's okay because these numbers are so good. So you can see, hopefully you can see that. That's clear to you. Same patient that we checked his ultrasounds, he had a 32% blockage in the bulb here and a 25% blockage in his left internal carotid. After 4 years, he had completely regressed the plaque, so it was almost not even visible to less than 20% on both sides. You can see that's important, the comparison of those two carotid ultrasound studies to show that there's regression of the plaque over that 4-year window of time. Now, this is a 48-year-old patient of mine. She had a gastric bypass, lost weight, and then regained about 130 pounds back. She came to me on a whole boatload of drugs with asthma and nearly pre-diabetic, almost diabetes range. She had fatty liver disease, asthma, and a whole slew of things going on. As you can see that over a 2-year window of time, we decreased her small particle LDL from 690 down to less than 90. With her diet, just diet alone. Fasting insulin dropped to below 5 from 222. Her A1C dropped from 5.7 to 5. She literally reversed her risk for diabetes. Her triglycerides dropped below 100. And you can see she dropped almost just over 80 pounds, or close to 80 pounds of weight. Now that's post-gastric bypass. Remember, she had a gastric bypass after 5 or 6 years, regained about 130 pounds, lost another 75, 80 pounds in that 2-year window. Doing dramatically well, and came off of most of these medications here, which is pretty profound to see that with her. She stopped her losartan, her hydrochlorothiazide, which is a blood pressure pills, and then the 2 cholesterol pill, gemfibrozol, and her Advair, because her asthma got dramatically better. And her blood pressure, you can see, dropped by 15 points. So really profound and important to understand. This is a patient. This is her. This is actually 5 years post-gastric bypass. She lost the weight, and you can see just in a few years, she looks and feels fantastic. So if you haven't started a ketogenic diet, you can start by, number 1, controlling your insulin resistance by decreasing your carbs to less than 20 grams per day. Number 2, you want to moderate your protein. The average female needs about 90 grams of protein per day, and the average male needs about 150 milligrams of protein per day. 150 grams of protein per day. Female 90 grams, male 150 grams per day, to further suppress that insulin effectively. Number 3, start with a ratio of 1-to-1 protein to fat. Once you're keto adapted, you may be able to decrease that fat slightly if you need to, but I usually start with a 1-to-1 ratio. So for every gram of fat, a gram of protein. Number 4, keep well hydrated. You need water. You need sodium, potassium, magnesium, and zinc. Otherwise, you'll get leg cramps. You'll feel fatigued, and you'll experience what's called the keto flu. Often it's related to salt being too low. And then eat when you're hungry. You can do timed eating, but I find that a lot of people have trouble getting the protein needs in if they're eating less than 2 meals per day. So be wary of that. If you need a copy of my ketogenic diet, you can go to darkmuscles.com and click on the ketogenic diet link, and it'll get you a copy of that ketogenic diet there. But hopefully this will give you some insight into how to get started if you haven't already started a ketogenic diet yet. And then we can talk about supplements. I've got a lot of information about my vitamins and supplements that may be helpful that way. But that'll at least get you started with the first 7 steps of starting a ketogenic diet. Remember, good judgment comes from experience, and most of that comes from really bad judgment. We learn a lot of things from our experience. This is me and my horse Bailey a few years ago. Hopefully that gives you some insight into cholesterol and a better understanding of what to do with cholesterol. This is really, in reality, the weapon of mass destruction. So you got to cut the carbs out, and that's what I keep telling my patients, to lower that cholesterol. So hopefully this little mini class has been great for you in regards to cholesterol and how to understand it when you're following a ketogenic or carnivorous diet. Check out my website, check out my blog, listen to our podcast, and you can find that at docmuscles.com. And thanks for joining us. Appreciate it much. Have a great day. Bye-bye.